My name is Andreas Kühnel. I'm the Managing Director of VSY Biotechnology, and it's my pleasure to welcome you here to our Satellite Symposium, since for us it's a very important event, since we are now introducing our new Enova Advanced EDoF IOL. And we have, it's our pleasure to have here some prominent colleagues from you who will talk about their first experience with our new innovative Enova platform, and will tell you why this is a new star on the horizon. And at the end, as you all know, also Dr. Florian Kretz will hand over and award the Ophthalmology Star Awards. So thank you for joining us. I hope and I'm convinced this will be a kind of an interesting session for you. And now I'm passing the ball to the first speaker. Thank you very much for joining us.
Yeah, hello, dear colleagues. I'm happy to present you about the new Enova IOL. I'm honest to say that I haven't implanted a lot, just started with that last week. I've only one happy patient. We have here at these ESCRS the new launch of this IOL, of this new EDoF technology, which is something very important for the company here. And what are we talking about? For me, the premium IOL market is growing, and especially the range of IOLs that we have is growing nearly every month. They all have different optical principles. The newer optics, they have reduced optical disturbances compared to the old, for example, trifocal IOLs of the new first generations. They provide better contrast sensitivity, they provide very high spectacle independence, and they are often more forgiving. So we have more happy patients. I think all these different IOLs and all this different technology make it very difficult for us and even for our patients. And the IACOS Society, they just started to make a new pronouncing of the different IOLs types. They speak about monofocal IOLs, then monofocal pro IOLs, like for example the new IOL from Rayner, and then the increased range of focus IOLs, which is the group of the EDoFs, and the full range IOLs, which are the classical trifocal IOLs. And I think this is very easy to understand, and this is also very easy to explain to our patients. So we have a lot of different optical principles, and we have the pinhole technology for EDoF, which I use in special corneas regularly, like for example the IC8 of Acufocus. The extra focus of Morsha is not on the market anymore. It's very sad. Then we have the Zeiss Lara, which I use regularly since a long time, which also provides very good spectacle independence in the intermediate range and less disturbances, but still some patients complain about night driving problems. Then another family, this is this Sigment IOL, the EDoF family of Teleon. We have the Lentis Comfort, the Femtis Comfort, and the Acronex Vario, which is also a hydrophilic IOL. And what I found interested is also the Femtis technology. Perhaps some of you know it. It's also an EDoF IOL, which is produced for the femto laser assisted cataract surgery. So we see that EDoF is absolutely growing. In my practice, I implant much more EDoF IOLs than, for example, classical trifocal IOLs. And so the company here also tried to bring a new technology in the market, and also not only copy something, but make a totally different new optical principle. So what is different? Florian later will talk a little bit more in detail about the optic principles. It's a new hydrophobic IOL. It's non-diffractive. And I think hydrophobic is also, for me, a plus. I switch much more from hydrophilic to hydrophobic again. In other countries, it's since a long time more in the hydrophobic field, but in Germany, there are a lot of surgeons who implant only hydrophilic IOLs. It's a non-diffractive light tailoring technology, and it has very good visual acuity for far. It should provide also a good intermediate vision and monofocal comparable quality regarding halo and glare at night driving. So yeah, it's launched on a next generation hydrophobic platform. It should be glistening free. A lot of problems regarding glistening we know from the past. It's dry packed, and the unfolding, which I saw in my patient, is very controlled. It's not too slow, not too fast, and you can really easily handle the IOL, and the learning curve is, yeah, it's still not existing. It's very, very easy to implant this IOL and to use the preloaded system. So we have the advantages. We have good distance vision, we have good intermediate vision, and we have also a little bit effect in the near visual acuity and very good halo and glare profile. Glistening is reduced, and these are the technical features of the IOL. We have a wide range of diopters, and it's 360 degrees square edge, so it has all the details which a new and modern IOL should provide. Here you can see the patient from last week. You can see the optics. This is what it looks like in the OR. Here you can see the optical system which provides the EDoF effect. So I told you already, Florian will go more in detail about the optical principles of the IOL. What you've seen here on the left side is what I showed you in the video, and we have in the center for far, and then also close to the center the optic region for the intermediate vision. I go straight here. So what you see here regarding the MTF values, you can see regarding 2 millimeter or 3 millimeter up to 4.5 millimeter how the optical principle works. And here you can see comparison to another well-known IOL, the ESCRS Vivity. So it shows comparable results, which is important that we see that a new IOL can absolutely compete to IOLs already on the market with different optical principles. So the theoretical defocus curve you can see here with a nice platform here which provides the good visual acuity from far to intermediate distance. Here the USF target images. Here a comparison also between the Enova Advanced and the ESCRS Vivity. These slides are provided by the company. You can see also that there is a very good contrast sensitivity and a good optical quality. Here again, regarding the intermediate visual acuity with a 3 millimeter pupil. So yeah, that was the first impression I had. That's also for me interesting because I use EDoF very long, and now we have another one, another hydrophobic IOL, which I really like. It has another optic, and we can have now more options for our patients, more individualized patient care if we have different IOLs, even if it's all increased range of focus IOLs that we can use in our daily routine. I think questions should be now, or shall we discuss later?
Yes, we said we do the questions after every talk. So is there any questions from the audience? It is a brand new lens, so there's not much data out there at all. So that is really something that I think has to be addressed. That
Yes.
from your feeling, do you rather see it more drifting into the monofocal pro area, or is it more drifting into the larger range of vision IOLs from your first patient experience?
Yeah, that's, from my personal experience, it's more drifting from trifocal to EDoF since longer time. And now I see in my practice also a higher number of monofocal plus IOLs, which I really like, yes. But for me only the younger patient who really works from 8 to 5 at the computer is a classical trifocal patient where I implant trifocals.
Where would you box this lens now? In the increased range of vision IOL group, or rather into the monofocal plus IOL group?
I would in the increased range of focus IOL group, yes.
And
not monofocal plus, no.
In your first patient, did they report any side effects or anything of it?
Yeah, it's too short, and in the moment it's not winter. I think winter time will be interesting for all these questions regarding night driving, but that's too early. Yeah.
Is there any more questions from the audience regarding? Yeah. Can you please come to the microphone?
Okay, thank you very much for the nice presentation. I want to ask you, what's the diameter of the central ring, and do you have any consideration for regarding kappa angle?
What is the?
Okay, so the question was about the central ring,
yeah.
And if there's, what's the cutoff value for angle kappa for decentration, basically, of the IOL? So what's the cutoff for the angle kappa?
Too early.
Yeah.
Can't say.
First, there is no ring, because
you.
it's it's a different way of treating the optic, and I think the central part is larger, so it should be less dependent for the angle kappa than, for example, a diffractive trifocal IOL. Okay.
You go on? No.
Thank you very much. Then our next speaker is Professor Oliver Findl. And
yes, thank you. So obviously also talking about the same lens, the Enova Advanced EDoF IOL, and here we're calling it an EDoF IOL, as you can see. These are my financial disclosures. We are performing a trial on this lens, which is currently underway, but it's underway, meaning we're recruiting patients, so I cannot give you any results yet. It's a randomized controlled trial against another so-called EDoF lens. So, but I have no personal financial interest. So I want to start talking about the need and the interest in this kind of, these kind of lenses, and then talk about non-diffractive EDoF design, some optical bench data, some material properties, and some early clinical results from another study which was underway. Here you can see the ESCRS survey, which we do every year. We usually have about 1,500 to 1,700 respondents, so quite a large amount, and you may be some of them. And we look over the years, we look for trends. And what you can see here very clearly is bifocal lenses essentially have reduced to nearly zero, to very low amounts. Trifocals have been winning over time, but now are stagnating since about 3-4 years. And the group so-called EDoF lenses, or maybe enhanced or enlarged range vision lenses, are increasing significantly. Be aware that the monofocal plus or enhanced monofocal IOLs haven't been part of the questions at that time. So the question also was, which is interesting, is what are the biggest concerns of you colleagues against performing such presbyopia correcting IOL procedures? And that's all presbyopia correcting IOL procedures now. And you can see, of course, cost of the patient, but also concern over nighttime driving quality and quality of vision at nighttime driving, and also to a certain extent concern over loss of contrast visual acuity. So it's quite clear that there is a trend, and we see that, and that was just discussed previously, towards these so-called EDoF lenses and also non-diffractive EDoF lenses, because we know that the diffractive EDoF lenses, which were the first to start with, we actually see dysphotopsia to quite the same extent as with trifocal technology, and that's not really the idea. The idea is to have a lens which will have less dysphotopsia. So this is the design. It's a hydrophobic material, which is known quite well, the Enova material. which is also being produced by the company itself from the raw material, so not being bought through another company. It has been shown to be glistening free, it's dry packed, and it has a relatively good glass temperature, meaning it has a very controlled unfolding. It doesn't give you a quick unfolding. They call something, they have introduced something called light tailoring technology, and I'll obviously show that you in the next few slides. And the idea is to really have very good and crisp distance vision, which I think is most important to most patients. And then to have ideally pretty good intermediate vision and useful near vision in some patients. And of course, trying to have a dysphotopsia profile that mimics that of a monofocal lens. So here you see the so-called light tailoring technology, which essentially has two modules to it. A central module, and this is a 2 millimeter zone, by the way. So this is a central 2 millimeter zone, and it's obviously exaggerated because you can see here we're talking about 1.6 microns. So this is an exaggeration in this image. So these are very, very slight changes in curvature, which you really can hardly see at all from the outside. And so this first structure, the so-called structure 1, they call it, essentially would give you this kind of profile, as you can see in the dashed line, which would mean pretty good far vision, moderate intermediate vision, but relatively poor near vision, as you would also expect for an EDoF lens. And then they've added essentially a second structure to it, which then gives you that resulting full lens orange line you can see here, with a very good intermediate profile, and actually even some quite useful near vision. Here, the design, if you want, compared to that of the Acris of Vivity, which some of you may know. Also very slight changes of curvature. And here, the transition element in the center is essentially neutral. And then they have essentially this ring, which you know if you've implanted Vivities, you can see that, especially in the specular image when you use a slit lamp. So some quite, I would say, significant differences between the two. Now let's have a look, and you've just saw this this diagram before. So for 2 millimeter, 3 millimeter, 3.75, and 4.5 millimeter aperture, you can see here essentially a optical bench distribution of light. And what you can see, and so these are MTFs, of course, and you can see for far, as the larger the pupil, especially in these mid-sized pupils, actually you can see a better distance MTF than is the case for the Acris of Vivity, which is in this case a comparator. And you can see in intermediate and near actually a very similar profile. So this looks pretty promising from that perspective. Here again, optical bench results, looking here again at different apertures. So this is the typical region we'll be dealing with in patients. And you can see here, this is for distance, and this is for intermediate. And then on the left side, the Enova, on the right side, the Alcon Vivity. So there are slight differences. You can see here again, for the Enova Advanced, slightly better distance, especially at this 2.5, 3 millimeter profile, and still very useful intermediate energy. So these are now theoretical defocus curves from this data, which you can derive from this kind of data. And what you can see here is, first of all, a monofocal lens, which has very good distance acuity, as you would expect, but then, of course, poor intermediate and poor near vision, as you would expect. And then here, in this case, the Acris of Vivity with slightly poorer distance acuity, pretty good intermediate vision, and also pretty good near vision. And that is something also we hear from our patients where we use the Vivity, that some patients are not quite happy with the distance acuity. It's just not really crisp. It's not really as good as they would expect. Other patients are happy, but cataract patients in general are happy, that we know. But those who are a little more, let me say, critical, that's something you hear once in a while. And that is also one of the big critical factors of the Vivity, otherwise being a good lens, no question. And then here now you can see the Enova Advanced, and you can see actually slightly better distance acuity, very close to what the monofocal does, very good intermediate vision, and near vision at least as good as that of the Vivity. And here you can see some USAF target images, in this case under photopic, mesopic, and scotopic pupils, and this is for distance, and you can see the Enova here, the Acris of Vivity here. So if anything, the Enova slightly outperforms. and then for intermediate vision, in this case with a 3mm pupil, and then you can see actually quite similar images. So obviously the intermediate function as good, but the distance a little better. And I think that is what this lens is probably about, to have a patient where you really have good distance vision, and then, as you can see, good intermediate vision, and maybe even some useful near vision. The glistening-free material, I mean, that may have already been discussed. So you can see here, and this is the Enova material is known since quite a few years. The Enova material here, in a comparison, this is from Nick Mamalis and Liliana Werner from the John A. Moran Eye Center in Utah, and you can see the Acrosoft and the Technis, and you can see that the Enova really is glistening-free. Here, what I told you about before, the biomechanical properties. So the glass transition temperature is reached at -2 degrees, and you can see the comparisons with the other lenses, which we're just comparing to now significantly higher glass transition temperatures. So you don't need to warm the lens or do anything, any preconditioning required, and it actually does a pretty gentle implantation. Here's just a short video. This is one of the trial patients we did several weeks ago or 2 months ago. This is the injector at the moment. Put the lens into the injector. Obviously, always watch the haptics. The lens goes into the eye. You can see the unfolding is quite controlled, so really straightforward. And in this case, in the eye. And then I think that's pretty much, there's not more to see. The lens looks essentially like a monofocal lens. You already saw the technical features, so I don't really want to dwell on those, but you can see 10 to 30 diopters, and again, here you can see the constants which are being used, a 6mm optic, 30mm overall, and you see a water content of 7%. This was an early multi-center trial which was done, and you can see here 92 eyes of 63 patients, and you can see here that the uncorrected distance visual acuity is very good, as you would expect, and the uncorrected intermediate visual acuity also very good, and actually in this case, in this study, with these 92 eyes, actually also very good near vision, so or quite useful near vision, let me say it that way. So to conclude, this is a novel, non-diffractive EDoF optical design. Has slightly more light to the distance focus, which I personally prefer. I like that, because distance for me still is the most important. It has a very good and surprisingly good near focus, especially on the optical bench, and you saw the comparisons. The material is well established, glistening free, and has a controlled unfolding. But of course, we need to wait for the real clinical data. And again, as I just told you, we're performing a clinical trial at the moment. So maybe next year I can share these results with you. Thank you very much.
Thank you very much, Oliver. And I think we already have the first question arising.
Yes, I do. Thank you for your talk. It was really nice. One question concerning with the vividity. We sometimes did a little bit of monovision, like correcting one eye really for the distance and one eye more for the near vision. Do you do the same with this one? With
yes.
I
mean, I think it really depends on your approach, absolutely. So when I use EDoF lenses, I try to go for at least half a diopter of monovision, even 0.75, and not always do we hit target, you know, that obviously we're tempting. There are some lenses, for example, which you would call more the monofocal plus lenses, where I'll go for a little more. It depends on what the patient also expects. For example, myopes, I tend to go for more monovision. 1 diopter, 1.25, why not? So I think you can play around with it, but I think if you want to have better near results and you want to have really good intermediate results, going for little monovision makes sense. And then the next question which will come up is a dominant eye question, usually. You know, does the eye dominance play a big role?
Yeah.
To be honest, we don't really know. I think the jury's out. There's no good research on that. I think there's also many patients who don't really have a strong dominance. There are some who do. The question is always, especially in a cataract patient, it's very difficult to establish that because they may have a quite asymmetric cataract, and then it's really difficult to do like the hole in the car test, for example, and other tests like that. So I think ocular dominance, I think, is a little overrated. But I think if a patient really has strong ocular dominance, they usually know.
Okay.
Either historically from taking photographs or from shooting with a rifle or whatever it may be. But I mean, that's a usual question we have when we talk about monovision, of course.
And I have one more question concerning the Enova that seems only to have a UV filter, whereas the Vivity comes with a UV filter and mono-blue, the blue filter.
Yeah.
Do you have any preferences? Seeing somebody has light AMD, would you rather say, well, you'd rather get a Vivity and you don't, or is it no aspect in your choice?
So this is a general yellow, not yellow question,
Yeah, I know.
but which is for monofocal lens, for every lens, right? And I am not a yellow person.
Okay.
Because there is no good data in the human at all. There has been some experimental data with very high UV exposures in vitro experiments, which were the basis for the yellow blockers. The original lens was Hoyer, in the 90s already, and then obviously Alcon joined that. And I prefer not to be quite honest. And we have some patients, actually we had them in a trial once with the Hoyer, which is a little more yellow, so more blue filtering, where actually the patients were able to say they saw a difference between the eyes. So that was a randomized controlled trial, one eye yellow, one eye not yellow. We're looking at all kinds of things. Pretty much everything was similar, but then patients said 3 of them actually saw a difference between the lenses. And interestingly, all 3 of them, they were also able to identify the eye, and all 3 of them had something to do with colors. So one was actually an artist, one was a photographer, and the third was a wallpaper person. Yeah, so they obviously all had an interest for colors, and they actually also noticed and perceived a difference. But I think, often patients don't. We also know that. So I am not a follower of yellow, and I simply don't think there's actually no proof that it works.
Yeah, I know. Thank you.
Pleasure.
Is there any more questions? Yeah.
I would like to know with the full collection for the first trial, if we for the binocular. How good is it, or how many percentage that the patient can see near?
Okay, so I think, so you saw these uncorrected intermediate visual acuities, 0.2 logMAR. That's pretty good. That means that will take care of most of the things you want to do. Maybe not under mesopic conditions, maybe not in all cases, like always. And you saw that even the near acuities, uncorrected, in this case 40 centimeters, was 0.3, which is actually also quite useful. So obviously, I always tell patients, if I do sort of EDoF style lens, I always tell them this, you need to be aware that if you want to do long time reading or small print or detailed work, or with poor lighting, you will need reading glasses. And if patients know that beforehand, and they're happy with that, they have reading glasses at home, but usually when they go out, for whatever they do, they usually don't need glasses. And I think that's what it's really about. But you need to make that quite clear to patients. If patients want more, then you have to go to the trifocal arena, but then, with all the issues you have with trifocals.
Thank you.
Pleasure.
Oh, sorry. Oliver, perhaps the audience is interested. The data, 92 eyes, I think it was. Who was the center?
That wasn't my data. I said it was a previous study. I believe that was in Turkey, most of that. And so again, the data is not from my center.
Yeah.
Oliver, I'm sure many people here are going to be interested in that lens now and they want to implant it. So when you choose your target refraction, are you coming from the myopic side towards it, or are you coming from the hyperopic side when you choose the IOL power?
Yeah, so I think for this lens, I will still come slightly from the myopic side, just because I want to keep the bell, my bell curve as much as possible, if at anything in the myopic side. There are some monofocal plus, or sort of, let's say, EDoF lenses, which have a slightly different defocus curve with a slight hump towards the plus side, where you can actually really go for complete emmetropia or even slight plus. For trifocals, we tend to do that. For bifocals, we used to do that, go a little into plus. I tend, with these lenses, to go for the first minus. Only if the lens is very close to 0, then maybe I'll go for the emmetropia lens. Do you have a different approach?
No, I actually have exactly the same approach.
Yeah.
And you probably have implanted the most from all of us here right now.
Don't know, somewhere.
Did you have any subjective complaints by the patients after the surgery, or so far they, when you don't ask, they sometimes they don't say anything either, and they're happy?
Exactly, so no complaints until now. I mean, the usual thing, patients are happy after cataract surgery no matter what you do, which lens you use, so that's always a very poor outcome parameter. especially if the study is not a huge study. If you have a study with many hundreds of patients, that may be different. So from that perspective, I can't really give you a good comment. We haven't had any disturbances, let me say it that way.
My patient was very young, not a typical cataract patient.
Okay.
She was 56 or something, with a very, very mild cataract, so good visual acuity before surgery. But I have only 1 week, but she's quite happy.
Yeah.
And can read, use print. I think one important question is when you start with a new IOL, and I'm always a little bit slow if there's no toric version, because you can't start really like you want to. So I think it's a very important question that we get to know when the toric version is coming.
Absolutely, I mean, you have to ask the company, of course. I mean, in the ideal world, would have the toric available from beginning on? Absolutely, because with these lenses, you want to address astigmatism aggressively, and it's quite difficult to recruit patients who really have little astigmatism in both eyes. You know, it happens, of course, and we have some, but they're actually not that many. So many will have 0.75 or 1 diopter in at least one eye, and then these are actually patients which, from my perspective, are not ideal patients for such a trial.
How would you categorize the lens now? In the monofocal Pro or Plus area, or rather in the increased range of focus area, from your early experience?
Yeah. No, so I think you know, from my perspective, it's one continuum, right? You have monofocal on the one side, and you have trifocals on the other side. And then you have this sort of bunch, which is monofocal plus. And then you have something we call EDoF, or you call a larger range of vision lenses. And obviously you come into the trifocal arena. And this is one continuum. You can't put a line. We love to put things into boxes, right? We like to have this box and then that box and then that, and we like these categories. That's the way we are. But I think it doesn't make any sense. So I think we need to look at the profiles of these lenses, at the way they are in the MTFs, in the defocus curves, and then we need to position them on that continuum. And what you call it at the end of the day, yeah.
Thank you very much, Oliver. And I think you...
No question from my side, but the toric lens will come in the third quarter next year.
Next year. Whew.
Thank you.
Yes,
that's a long time.
Third quarter.
Third quarter next year.
That's a whole year.
A long year to test the non-toric version, yes, correct.
All right, so now you know.
Thank you very much, Oliver. And we will now switch to Professor Achim Langenbucher, and he will explain a little bit more about the technical concepts and actually the MTFs on the optical benches and how this IOL really works.
So, good afternoon, everybody, ladies and gentlemen. I would like to talk about the on-bench measurements, what we did with the Enova Advanced, with the classical monofocal Enova, and some other competitor lenses in our lab in Saarland University. So, first, let me show the results of the classical Enova monofocal lens versus the EDoF lens. I call it now EDoF lens, but maybe we had some discussions in the past. Which classification is the correct one. So first, the results, what we did with the NEMO for the two isoconform aperture diameters, 3 and 4.5 millimeter. On the left side, we did the results for the classical monofocal Enova, here for the 3 millimeter and for the 4.5 millimeter. And on the right side, for the advanced also with the 3 and 4.5 millimeter. What we see for the monofocal lens is a typically nearly diffraction limited situation here. So that is a diffraction limit, and we are very close to the diffraction limit. The red dashed line refers to the 100 cycles per millimeter. That means it's the contrast transfer for a visual acuity of around 20/20. For a larger pupil, like all lenses, we have in the monofocal lens a slight decay. And if we compare the results of the monofocal lens with the advanced Enova, we see that the decay of contrast transfer is slight. So we have maybe a loss of 10% only, which is quite good for an EDoF lens with some enhancement for intermediate vision. And it's the same if we compare the monofocal lens here for the large pupil with the Enova Advanced. It's only a slight decay in contrast transfer of around 10%. Then we used the optospheric, it's a different instrument for measuring, for example, the power profile. And we have to distinguish between radial power and between tangential power, because the tangential power is not important for ray tracing or for imaging performance. So what we have to consider here is a blue line. And here again, the Enova with 3 and 4.5 millimeter pupil, and on the right side, the Enova Advanced, the EDoF lens, again with the 3 and 4.5 millimeter pupil. And what we see, the typical behavior of a monofocal lens with one straight focus. It's one peak only here in the blue or here in the blue. That is a typical behavior. So in the Enova Advanced, in the EDoF lens, we have the typical peak here for the far vision and some additional power, which is around 1.1 up to 1.6 or 7 millimeter higher than the nominal power of the lens. That means this 1 to 1.1 up to 1.7 diopters more power is giving us typically an intermediate vision of around 1.1 diopter at spectacle plane. And if we consider the same lens for the larger pupil, for the 4.5 millimeter pupil, it behaves somehow here like a EDoF lens with a large, broader landing zone, how you call it, and an additional second focus for intermediate vision. That means you have a pushing of intermediate vision even in the 4.5 millimeter zone. Let me show you the best focus MTF measurements. Same situation, 3 and 4.5 millimeter. Here the monofocal on the right side, the advanced, the Enova Advanced. And again, we have with this instrument a close to diffraction limit imaging performance of the Enova monofocal lens and a slight decay for the larger pupil. And also the Enova Advanced shows a really good imaging performance, a good contrast transfer for both the 3 and 4.5 millimeter pupil size. Next, the US Air Force target. So we did it for different pupil sizes, again for the 3 millimeter pupil and again for the 4.5 millimeter pupil, what I will show you in the next slide. So the comparison of the Enova, the monofocal lens, and the monofocal and the advanced, the Enova Advanced, here for the best focus, and then we see a strict decay, which is quite typical for a monofocal lens. So a monofocal lens is not designed for intermediate or near vision. Therefore, the contrast is directly decaying, and maybe it's good from 0 to half a diopter, but not more. But in the Enova Advanced, in the EDoF lens, we see a very good contrast transfer from the best focus in the 3 millimeter aperture version up to 1.25 diopters, which means it's a distance, an object distance of down to 80 centimeters. So between infinity and 80 centimeters, it allows a good contrast transfer. Same situation for the 4.5 millimeter pupil. Again, the monofocal lens in the upper line, the Enova Advanced in the lower line. Very good imaging performance in the focus, but a strict decay typical for monofocal lenses, and in the Enova Advanced, we have more or less a continuously good contrast transfer up to 1 diopter, and after 1 diopter it's slightly decaying. So for a large pupil it allows for infinity to 1 meter, for the smaller pupil from infinity to 80 centimeters. Next, I would like to show you the comparison between the Enova Advanced and some other EDoF lenses on the market. First, the NEMO results. That result we saw already in the previous section. But if we compare to the Alcon Vivity, which is also a refractive raindrop design, so which means with an elevation of refractive power in the central zone, we see a very similar behavior, maybe slightly lower contrast transfer of the Vivity here in the low spatial frequency, but here some bump in the higher spatial frequency. And the Symphony and the Zeiss Lara are diffractive lenses, bifocal or trifocal diffractive lenses, which are not as good for far distance vision because they are giving more weight to the intermediate vision. Here it's the same situation for 4.5 millimeter aperture size. For the best focus situation, again the VSY Enova Advanced, the EDoF lens, in contrast to the Alcon Vivity, the refractive EDoF lens, and the 2 EDoF lenses with a diffractive grading. So it's a really good imaging performance, only a slow decay in contrast to the monofocal lens. Let me show you the power histogram for the lenses for the small aperture, for the 3mm aperture. Again, we saw it for the Enova in the first section. And if we compare the power profile with the Alcon Vivity, we have a different configuration here. So we have the double ripple here in the Vivity, or the strict bifocal behavior in the Symphony, which is a diffractive bifocal lens, and some continuous way from far to intermediate distances in the Zeiss Lara. Here's the best focus, MTF, again measured with the optispheric. That image we saw already, and if we compare this image with the Vivity, it's quite comparable. So the integral under the curve is more or less the same for the Enova Advanced compared to the Alcon Vivity, or for example to the Symphony or Zeiss Lara. So it's a good lens on the market, and maybe it will establish as a good EDoF lens in the future. Last but not least, I will show you the power histogram for the lenses for a 4.5mm pupil. And for the 4.5mm pupil, I told you already, we have a broadening here of the power profile, plus 1 extra peak for intermediate vision, which is pushing a bit the intermediate vision. So from the profile, it's pretty much similar to a good combination of the Alcon Vivity with a single peak, only a little bit broader than a monofocal lens, and the Johnson & Johnson Symphony. So it's somehow a combination. Second peak here in the Symphony, what we find here, and a little bit broader behavior of the Vivity, what we find here. The respective modulation transfer function measured with a large pupil size of 4.5mm are shown here. That image we saw already. And if we compare to the Vivity, the integral or the area under the curve is more or less the same for all the lenses, for the Enova Advanced, for the Alcon Vivity, the Symphony, or the Zeiss Lara. And last, I would show you the US Air Force target measurements for the 3 and for the 4.5mm pupil. Again, in the first line, the VSY Enova Advanced, in contrast to the second refractive EDoF lens, the Vivity. It's quite comparable for all the distances. So you have more or less the same contrast transfer for objects at infinity, for objects at 1 meter, for example, on 1 meter, for example, or up to 1.25 diopters of intermediate focus, which refers to 80 centimeters object distance. In contrast with the diffractive lenses, the Symphony and the Zeiss Lara, we have less weight to the far focus, what we see here with a slightly decayed contrast transfer for far distance, but we have some pushing for near vision or for intermediate vision around 1.25 diopters of accommodation. That means 80 centimeters. And last slide is the US Air Force target measurements for the larger pupil, for the 4.5mm pupil. Again, we have very similar behavior of the Enova Advanced compared to the Alcon Vivity for the entire range up to 1 diopter. It's up to this range, and completely different behavior with the diffractive lenses, which have a lower contrast transfer for far distant objects, but maybe some pushing or some more weight for intermediate objects with a distance of 80 or 100 centimeters. Let me conclude. The Enova Advanced is a classical refractive rotational symmetric, so-called raindrop design EDoF lens with a light tailoring technology and with power elevation in the central zone. Based on the hydrophobic 100% glistening-free monofocal Enova platform, it has to be proven by clinical studies. We expect that with a nominal spherical aberration correction of minus 0.1 micrometer in a 6mm zone at corner front vertex plane, it improves intermediate vision at a depth of field from infinity to 80 centimeters for the smaller aperture size, or up to 100 centimeters with a larger aperture size, without any clinically relevant performance loss for far objects. And the expected clinical performance should be, from our point of view, comparable to other refractive EDoF designs, such as the Avdanced, the Vivity, the LuxSmart, or the Hoya EDoF lens. Thank you very much. Are there any questions?
Any questions from the audience? Oh, I have a question, Achim. Did you also check the influence of decentration or of tilt on the optical quality with those IOLs?
Not now. So till now we made only central measurements. So some on-bench measurements are still on the way, so we will have it maybe for the next Congress for the DOC in Germany or whatever next year, but they are on the way.
And which cornea model did you use for the measurements at the moment?
We use the model cornea with 0.17, which is in between, which is normally used for many lenses, for the Hoya lenses, for the Alcon lenses, and which gives good average performance for most of the lenses on the market. So there are two ISO standard lenses, model corneas. One is with 0 aberration, so it's the aberration-free one, it's the ISO 1, and the ISO 2 with 0.27 or 0.28 microns, but we use the 0.17 because it fits mostly to that what we measured, for example, with tomographers. It's the average spherical aberration, what we measured up to now in our clinical lab.
And would you expect any change in the MTF curves, for example, if the spherical aberration of the cornea would increase or decrease? Or do you think that that lens would also perform well in, let's say, a plus 0.4 micron spherical aberration cornea?
If the spherical aberration of the cornea increases maybe to 0.25, 0.26, 0.27, we expect that a more aspheric lens design, for example, the Avdanced, could have a better contrast transfer, or if the individual spherical aberration of the cornea is lower, maybe it's aberration-free cornea or has only 0.1 micrometers of spherical aberration, we expect that the results of the Enova Advanced might be better because it has a low, a moderate or low spherical aberration correction of only 0.1 microns.
Thank you very much, Achim.
Thank you.
So as you all heard, that lens is pretty new, so there's not much data available. That's why I will just have some slides that are going to be repeated. My name is Florian Kretz, and here are my financial disclosures. You already saw that slide before, and actually there's like one comment I want to make to that slide. At least in my practice, yes, the percentage of my trifocal lenses are decreasing, but the overall volume is increasing because my monofocals are the ones that decrease the most, and they increase all my increased range of focus IOLs significantly. So I think there's always a relation that you have to see when you look at percentages, is from which numbers are you coming from. So the Enova Advanced is a non-diffractive hydrophobic EDoF IOL. It's a new A-class product of VSY, so it has their full concentration. It's supposed to give excellent visual acuity for far, great for intermediate, and still slightly near, and it should perform like a monofocal regarding this photopsia. And I think you already saw, especially from the optical bench data, that that is absolutely realistic. You could see all the other values: glistening-free, dry-packed, controlled unfolding. The dry package actually gives you a very small lens book, so your consignment stock is actually very easy to store, and you also are more sustainable because you have less garbage unpacking it. You have sharp vision for far, you have a very good intermediate vision that could be proven on the optical bench, and you still have a near vision effect. And 0.3 logma, what was shown in the study before, is actually what the average person needs to read newspaper print in 60 centimeters on the table in front of them. It's a glistening-free material, which is very important, and actually it's a hydrophobic material that unfolds very controlled and not too slow like with other IOLs. You saw that slide before, so there's not much to really say about it, but you can see the curvature change on the, in the central tailoring part, and what gives you the intermediate effect and the defocus curve. I think here we can jump over that one we already saw before, and you can see here the theoretical optical bench defocus curves, which pretty much also match what Achim has showed you, who remeasured the IOLs himself on his optical bench at the University of the Saarland. Light distribution, you can see the central bump is was slightly steeper than it is actually in the Vivity. That's why the light distribution for intermediate is also slightly higher in the very center. If we think about diffractive lenses and the intermediate effect in a trifocal lens, in most diffractive trifocals, the intermediate is only in a range of 7 to 12% of the light energy. And that's why the contrast with those types of IOLs is significantly better compared to a diffractive trifocal. The defocus curve you have seen before, and you can see it has a great increase in defocus. The pupil dependency, well, like I said before, the lens is pretty new, so there's not much data out there, but you could already see on the remeasurement beforehand that it really gives you a long defocus, and it's not that dependent on the pupil size as some other models, especially comparing like the 3mm aperture to a bigger one. It's glistening free, which is a benefit because glistening can also cause dysphotopsia, and so that is a true benefit of the IOL, and actually it was examined in the University of Utah regarding the material, so that's a claim that the company can actually like hold up in the future. It has very good biomechanical properties with a 7% water content. We have seen this one before. It actually comes in a very easy, handy injector to load, going through a 2.2mm incision. Those are the early multi-center results that Oliver has seen, but I was also showing you the refraction analyzed. And that's why Oliver and I also rather come from the myopic side, because you can see there's a slight hyperopic outcome in those cases. And with those newer lenses, you sometimes really have to see that you don't come too hyperopic when you start using them. Well, I actually do have some data available that I'm going to show, because I did have a patient that's implanted now for 1 month. You can see here the pre-op finding, pretty straightforward, normal axial length, normal K values, hardly any corneal astigmatism, slightly hyperopic refraction, and reduced logma visual acuity due to cataract. And you can just see here the surgery. It's a pretty normal eye, grade 2 cataract. I do all my surgeries just with HPMC, 1%. Manual capsulotomy with the Utrata, so nothing really like special about the surgery. It's all done in topical anesthesia, no blocks. I give intracameral lidocaine for the hydrodissection. It was actually a very soft cataract, so the chopping is easy and the extraction of the lens goes pretty fast. And soon comes the interesting part when you're going to see the IOL. So we do a little polishing. Remove the remnants of the cortex. I think if you do a good hydrodissection, then there's hardly any cortex left anyways in those cases. And compared to the other videos you saw before, I'm a lazy surgeon, so I don't use viscoelastic for the implantation. So you can see here the lens, I'm lying it on, and I'm giving you a magnification, so you can see the inner ring of the C-loop lens. It's a clear material, and you can also see the 360-degree sharp edge on the haptics and on the optic. The lens is very easy to load in a regular injector or in the Acryjet injector. You just push the optic underneath the branches of the cartridge, and then you just carefully fold and bend the haptics a little bit, and that's about it, and you can close it. And I use an irrigation port to stabilize the anterior chamber, implant the lens. It comes out very easily. You just put it in the capsular bag, and the little bit of HPMC that comes with it, you just extract, polish behind the lens, and basically then the surgery is done. And you will see a magnification soon again of that central ring, very similar to what Detlef has shown you before, but that's basically all you see. And as you saw in the video, during the eye movement, you actually do very hard to identify the central refractive zone that is responsible for the effect. So nothing complicated, but what's the outcome? So that's my one patient after 1 month. We had a slight hyperopic outcome in the subjective refraction. So in the future, we are even going to go quarter a diopter more from the myopic target. But we did have a corrected distance visual acuity of 0.0 logma in the right eye, minus 0.1 in the left eye. Distance corrected intermediate for me is always important because that really shows the true intermediate performance. 80 centimeters, 0.2 on the right, 0.1 on the left. Distance corrected near and 40 centimeters, 0.5 on the right, 0.3 on the left. If we go for the uncorrected one, even if we had a hyperopic outcome, the distance visual acuity was still 0.0 logma and minus 0.1. So that can be the difficult in those types of lenses, that sometimes your subjective refraction is actually not as precise as you want it to be. So for me, that is a hint we need to control that patient a little bit closer. But the uncorrected intermediate was 0.3, 0.2, and the uncorrected near in this case was only 0.8, 0.5. But that patient was not counseled to get near vision. It was counseled to get good distance vision and good intermediate vision. So actually, at least from my feeling, the lens did what it promised on the packaging in that first patient. So my conclusion is the first postoperative visual acuity results are positive regarding the far and especially the intermediate vision. The basic reading capabilities for near visions are maintained. Refractive errors are in an acceptable range. Personally, I would go for a slightly more myopic target in both eyes and look at the performance again. I did not see any glistenings after 1 month. The lens stayed very well centered. There were no adverse events so far, and I haven't heard of any adverse events from any of the other surgeons that have used it. So our early results are very promising, but still, it's a very low amount of numbers. 1 patient, 1 month. Detlef has 1 patient, 1 week. I have another patient that comes to the 1 month follow-up in 1 week, and probably Oliver only has a handful of patients too. But it's promising, and with that, I think it's a good alternative to the other ones on the market. Thank you very much for your kind attention.
Thank you very much, Florian. Are there questions from the audience? Yes, please.
I would like to know, maybe it is too early, but what is the rate of the PCO, and is the lens has the square edge?
The IOL does have the square edge, and it's based on the monofocal hydrophobic IOL from VSY, and that has a really low rate of PCO already. So as the PCO is more dependent on the sharp edge of the IOL, I think we can assume and say that it's going to have the same PCO rate like the regular Enova, which is quite low.
Thank you.
Florian, I think your conclusion was very interesting, and especially I also talked about it in my presentation about the more forgiving new IOL technologies. And what we could see, even it's only 1 patient, was that 1 eye was plus 0.75 but had 0.0 far distance uncorrected.
Yeah,
so it's very forgiving. And
but the question is it really forgiving, or maybe do we need to practice refracting a little bit better?
Yeah, it was subjective refraction.
Yeah, subjective refraction.
Yeah, can you give a comment to the automated refraction? Does it work, or is it?
No, to be honest, I didn't look at the data of the objective refraction, but usually I don't trust objective refractions in any type of presbyopia correcting IOL.
Absolutely, yes. Yeah.
There's one question.
One question. What is a typical patient profile for this lens? What do you feel, what could be the perfect patient?
Oh, I think there's no real age profile in presbyopia correction anyways. It's always depending on the demands of the patient, and it's depending on the ocular findings, what type of IOL is suitable for the patient. You can have a young patient who is a sniper and you put a monofocal aberration correcting IOL in, and he will be the happiest person ever, and he doesn't mind to wear glasses when he reads at home. But you can also have a disabled person sitting in a wheelchair where you implant a trifocal, and that patient is happy because he might have a stiff neck and difficulties with progressive glasses. So yeah, I think it's more an individual finding than actually that you can really define that's the age group or something.
But at the end of the day, if you start with EDoF IOLs, I think the best patients to start with is the cataract patients who has no problem if you tell him that he has to use reading glasses for long reading of small print.
Yeah. There's one more question from the audience.
Do you prefer to mix-match EDoF and trifocal lenses?
Oh, okay, the question is if I prefer to mix and match EDoF and multifocal lenses. My answer is I don't like to mix and match two different optical profiles, because it's the same when you mix and match lenses with a different filter. If the patient is capable of seeing well and understanding it, they will see the difference from the dysphotopsia and from other levels. So I like to mix and match lenses that are based on the same platform, and they might have different near-add powers, but not really to have different optical profiles.
Thank you very much.
Okay,
one
then
question maybe, same question what we had before. Do you call it EDoF lens or do you call it monofocal plus?
now I put it in the segment of the increased range of focus IOLs, because it does give you a functional near vision, but not a true near vision, and it does give you a good intermediate vision. To be honest, if it's after me, I would cut out the range of monofocal plus IOLs, because I don't really, at least in my experience, my regular monofocal patients have a very comparable defocus curve compared to my monofocal plus. So it's rather increased range of vision or it's full range of vision, but the monofocal plus is too dependent on the corneal spherical aberration of the individual patient, and not, it can't promise you too much.
Thank you very much.
Okay, then we continue with the Ophthalmology Star Awards. So if any one of the people who's going to win a prize is here in the audience today, we have those prizes here sponsored by WeSY. I would be very happy to have them come up, and our overall winner is Coen A. van Overdem with the clinical study title Novel Insights into Pathophysiology of Proliferative Vitreoretinopathy, the Role of Vitreoschesis-Induced Vitreous Cortex Remnants. So, Mr. van Overdem. Congratulations. Very well deserved. Okay. And the second prize goes to Anna Tarkova with the clinical study title Pars plana vitrectomy for vitreoretinal interface disorders coincident with intermediate stage age-related macular degeneration. So is Mrs. Tarkova, there is someone else from the study group taking it. Congratulations. Very well deserved. And the third prize goes to Nanji Lu with the clinical study A New Keratoconus Staging System Based on OCT. Congratulations. So I think with that we can close the session. And thank you very much to WeSY and the whole team also for the awards right now. I think that's a really great thing to support young ophthalmologists in their career and rewarding them for their great scientific work. And thank you very much also to my co-panels that helped me today. Have a great afternoon.